I appreciate being here. My name is Brian Steixner. I'm a board certified urologist. I did my residency at the University of Pennsylvania, went on and did additional training in sexual medicine. I'm currently the chief of urology at my medical center. In addition, in 2019, myself and Dr. Josh Gonzalez, who's an additional fellowship trained sexual medicine doctor, launched a company called Popstar Labs. The goal was simple: to develop high quality solutions for sexual wellness for men, both over the counter and prescription based. And so I'm honored to be here talking about a subject that we don't speak about a lot, but is incredibly important, and that is premature ejaculation, demystified from diagnosis to delay sprays. We'll go beyond delay sprays tonight. We'll go into all the medical options as well, not just the over-the-counter options and first-line therapy. So let's get started. So we're going to discuss 4 things tonight. We're going to discuss premature ejaculation and its subtypes. We'll talk about the biological, psychological, and lifestyle causes for premature ejaculation. In addition, we'll talk about the diagnosis and workup and some of the evidence-based treatment options available for us today. So what is the definition of premature ejaculation? The ISIM defined it in 2014 as 3 things. The first is time-based, and it is ejaculation that will occur within 1 minute of vaginal penetration from your first sexual experience. That's known as lifelong or primary PE. Acquired or secondary PE is defined as sexual intercourse lasting less than 3 minutes after having a period time of normal. I do think for us moving forward, we don't need to define sexual activity as vaginal penetration. One thing that I think the ISSIM needs to catch up with is that vaginal penetration isn't always defining sex. So when you speak to your patients, make sure you're aware that not all people are having vaginal sex, that there is anal sex, oral sex, and sex looks different to people. In fact, I have a lot of patients who see me who have premature ejaculation who are not in relationships and are practicing solo sex, and it is just as important for them. The other definition requires 2 things. It requires this to happen on nearly all penetrations and that to have negative personal consequences. It's important to point out that although this is a time-based diagnosis, that not all time-based diagnoses are having consequences. We have some patients who see me who can have sex for 30 seconds, but it doesn't bother them or their partner. And so it's actually not meeting the criteria of premature ejaculation. In the most recent DSM, the DSM-5, premature ejaculation was added, and there's one slight difference. It largely accepted the ISSM definition. However, in the DSM-5, it does say that it has to happen for at least 6 months for it to be defined. One other thing to add to this, when we talk about premature ejaculation, we often talk about time. So primary PE is lasting less than 1 minute, acquired or secondary PE is lasting less than 3 minutes. But the time-based definition not only is not always a problem for some patients, it's also time isn't always the same. So time isn't a constant in this world, meaning a lot of patients have different thrust rates, something that's poorly defined in the literature. And I'll have patients who can have sex for 2 minutes, and that can be enough for meaningful activity because their thrust rate or intravaginal, the amount of times that they're going in and out, can be double or triple someone who actually lasts much longer. And so when I talk to these patients, a lot of times I have a caveat of asking them how long they last, but within the time that they last, how fast are they actually going? And I think we see that the ISSIM definition in the future evolves to include that as a more realistic understanding of what's actually happening in the bedroom. Epidemiology and impact of premature ejaculation. Premature ejaculation affects up to 20 to 30% of men worldwide, making it the actual most common sexual dysfunction among men. So we're talking about the single largest sexual medicine complaint in men in this country and worldwide. It can appear at any age, but we do see that it has particularly common prevalence in younger men, and the impact extends beyond the individual. This affects partners, relationships, and overall quality of life. It's important to talk about PE in a different light than we talk about a lot of the other major issues we deal with in sexual medicine. Unlike ED, low testosterone, Peyronie's disease, male factor infertility, the common things that we see in our practices that do have a pathophysiologic basis, premature ejaculation is actually evolutionarily advanced. And when we talk to these patients, a lot of times they come in with anxiety, they come in with they're distressed about this diagnosis, and it'll put them at ease if you let them know that the quicker you ejaculate, the better it is for our species, for reproduction and the passing on of our genetic material. And so when I meet these patients for the first time and when I speak to them and we develop a relationship, it sometimes de-stresses the environment to let them know that having premature ejaculation, by definition, is actually evolutionarily advanced. So it's important to point that out, that although this is perceived as a problem to men, by definition, it's actually something that should not be considered a problem. There are two main types of premature ejaculation, lifelong or primary. Primary premature ejaculation is defined in less than 1 minute, but has occurred from your first sexual experience onward without much change. Acquired or secondary premature ejaculation develops after a period of normal ejaculatory control and is defined as less than 3 minutes after that period. There are two other types of premature ejaculation. One is known as natural variable PE, which is short intravaginal ejaculatory latency times, but that are irregular and inconsistent. So these are people who have normal sex. They can last normal amounts of time, but every now and then they'll have a variable amount of PE. And then there's subjective PE, which these men can last for 5 minutes, 10 minutes, but for them, it's still a problem. And they're coming to see you because of perception that they need to last for a half hour or an hour. And this may be largely contributed by abnormal stereotypes within pornography. This is also important because the workup for these two patients is, although it's the same, it's more focused in my practice. When I have someone who has lifelong or primary premature ejaculation, I'm largely thinking of a genetic or a neurobiological cause. But when I see someone who has acquired or secondary premature ejaculation, I begin to think of other medical issues or psychological issues that may have come up in their care or in their life. And so the workup is a lot more focused on seeing if there's something causing this, not something that they were born with. Let's talk about the biological causes of primary PE. And it boils down to serotonin. Low serotonin has been correlated with premature ejaculation, one of two main causes. Serotonin acts as an inhibitor of ejaculation by binding to receptors at the brain and the spinal cord. 5-HT1A and 2C are the two receptors involved in serotonin control of ejaculation, and both of them work to suppress the neural signals that trigger ejaculation. Serotonin also helps to control the threshold of ejaculation. So higher levels of serotonin will increase that threshold, allowing you to delay ejaculation. In a kind of an opposite effect, serotonin modulates arousal, but this is more early on in the stages of sexual stimulation and actually works to enhance arousal. The clinical implications of this have to do with premature ejaculation being caused by low levels of serotonin. And what we know is that when you give a patient a selective serotonin reuptake inhibitor, an SSRI, you'll increase serotonin levels, and that will lead to the treatment of premature ejaculation, or as a side effect, we'll often see delayed ejaculation or anorgasmia. Also, biological causes may be related to penile sensitivity or lower ejaculatory thresholds. And we'll get into the details about genetic factors and the neurobiology how they play a role in primary premature ejaculation. Psychological causes are also incredibly important. Whether or not this is primary, some men with primary PE will link this to psychological causes, but also acquired PE. Performance anxiety, the fear of disappointing a partner, these can accelerate ejaculation and make it worse. We know serotonin is at play in anxiety and also in play in premature ejaculation. That's why SSRIs are the treatment option for both. So low serotonin can be linked to anxiety, and you use an SSRI to increase that serotonin. Same thing with premature ejaculation. Relationship conflict or stress can often worsen the condition, cause a focus on it. And early sexual conditioning, such as rushing during teenage sexual activity, rushing during masturbation, may set lasting patterns that rewire these patients to have a long-term problem with premature ejaculation. I have to point out some contributing factors when we're talking about premature ejaculation. Erectile dysfunction and prostatitis have been linked in the literature as overlapping conditions. When it comes to erectile dysfunction, a lot of these patients will have lasting issues. When we talk about erectile dysfunction, we talk about the inability to achieve or maintain, and most of us know in our practices that maintaining erection is the bigger issue. And so if you have a man who has lasting power issues with erectile dysfunction, they'll often rush to reach orgasm. And by rushing before they lose their erections, they'll end up with a secondary problem, premature ejaculation, and that'll lead to conflict in the relationship. There is scientific proof that prostatitis and premature ejaculation are overlapping. The exact mechanism is poorly understood, although it is believed that prostatitis causes heightened sensation. And by having heightened sensation, it leads to increase in the sensitivity of the reflex network and will lead to increased risk of premature ejaculation. Endocrine disorders are also important. Both the thyroid and the testosterone axis, the hypothalamic pituitary thyroid and the hypothalamic pituitary gonadal axis, are modulated by serotonin. And so hyperthyroid conditions and its impact on the sympathetic nervous system can lead to premature ejaculation, and hypothyroidism in the same mechanism can do the same. As always, substance abuse issues can contribute. Alcohol, stimulants, drugs, those both work on the central nervous system and can have an effect on your neurotransmitters, leading to anxiety, leading to depression, and leading to an overlap in premature ejaculation. So what do we do when we see these patients in the clinic? History and physical are critical in these patients. Talking to the patient about sexual history, understanding how long this has been happening, when it first happened, how often it happens, the frequency, and actually how much stress it's causing these patients. I also always say that it's important to bring your partner to the office because the impact on the partner can be as, if not more important than the actual patient. So exploring the partner's perspective and understanding how big of an issue for them it is important part of history. A physical exam can be important at times. I do a general exam on all these patients. I'm looking at the sensitive areas. I'm looking for phimosis. I'm looking for balanitis. I'm looking for a frenulum that is too tight that could benefit from a release. I do a prostate exam on these men. I'm looking for prostatitis. I'm looking for a sensitive prostate. I'm also looking for a tight pelvic floor, which I think has a lot to do with premature ejaculation. There is overlap with pelvic pain symptoms as well. If you have someone who has neurologic issues, we're talking Parkinson's, MS, spinal cord injuries, sometimes addressing those issues can have an impact on their premature ejaculation. And anyone who sees me in the office who has premature ejaculation, I'm getting a hypogonadism panel and a thyroid panel as well. So the workup is pretty easy with these patients. Your history and your physical exam are going to dictate what you're dealing with, whether or not they meet the definition for premature ejaculation, whether or not they have subjective premature ejaculation. If they do meet the criteria, are there any other medical issues at play here that could be treated? But once we go through that and we've defined them as actually having acquired or lifelong PE, then we step into the treatment options available, which is the point of this lecture tonight. I will point out that patients who have acquired PE, there is a larger prevalence of anxiety and psychological issues at play. And so I do put behavioral and psychotherapy as the primary one. You have to be sure not to neglect that. With lifelong PE, you know this is likely not due to anxiety or to a medical comorbidity. This is genetic, it's neurotransmitters, it's neurobiologic. I lean into doing pharmacotherapy or over-the-counter or behavioral therapy or some combination of them earlier on. Okay, next. What do we start with? The first thing we always start with is the basic stop-start technique and the basic squeeze technique. Both of these are non-pharmacological strategies. I don't have a lot of success with these. Full transparency, starting and stopping decreases sensation. It makes sense. But a lot of times these patients reach what they call the point of no return before they can stop and start. And so getting them to reach that point beforehand is often very difficult because we're talking a matter of seconds here. But I do train everyone in the start and stop technique, and I do tell them to squeeze the glands of the penis to help stop that reflex from happening. Cognitive behavioral therapy, this is critical. Anyone who sees me in the office, I think can benefit from sex therapy. I also think anyone who sees me in the office can benefit from couples therapy. This typically has been something they've been hyper-focused on. They are incredibly distressed about this. They have anxiety. And so talking to someone about these psychological issues can have a greater impact on their health as well as impact their premature ejaculation. Pelvic floor physical therapy is something that's undergone a bit of a renaissance recently in the sexual medicine world. Outside the sexual medicine and our voiding dysfunction world, we see a lot of people leaning into Kegels exercises. Strengthening that pelvic floor has a huge impact on erectile function, on voiding dysfunction, on pelvic pain syndrome. The problem for me is differentiating what type of pelvic floor physical therapy is going to have the biggest impact. There's two different schools of thought here. Some people believe that Kegel exercises, strengthening the pelvic floor, allows you to prevent ejaculation from happening when you get to that point of no return. However, some people will tell you if you strengthen the pelvic floor, you'll actually shorten that time before you get to that point of no return, which is actually counterintuitive to what you're trying to do. And so I have a lot of patients in my office who will never get to that strong pelvic floor, strong enough to get them to prevent orgasm. And so actually teaching them reverse Kegel exercises will actually soften their pelvic floor and delay the time to reaching the point of no return. So it's a nuanced conversation, but regardless, pelvic floor physical therapy and teaming up with a good pelvic floor physical therapist in your community can have a dramatic impact in the quality of this patient's care. So my first line therapy is what I call topical agents. I will add to this list that condoms can also be a topical agent. Regardless of what you choose, condoms or some sort of analgesic or delay spray, you're decreasing sensation. And so the two main ones are a delay spray like lidocaine or benzocaine, or condoms. And there are condoms that are currently impregnated with lidocaine and benzocaine. The market for condoms has decreased a lot. Unfortunately, I think condoms are wonderful. They're good for pregnancy prevention for people who do not want to plan a family. They're also good for STD prevention, and they delay the time to orgasm by decreasing sensation. So in my book, condoms are the win-win. However, I have patients who see me every day in the office. In fact, I'd say the larger percentage of my patients prefer not to use condoms. And so if condoms are not an option, the next best thing is lidocaine and benzocaine delay sprays. These delay sprays are designed to, can you go next? These lidocaine and benzocaine delay sprays are designed to desensitize the penile nerves. Typically what they do is I tell my patients, we'll get into the nuances of which one I use and which ones I pick, but for all of them, I tell these patients, when you think the time is right and you're approaching having sexual activity, to sneak into the bathroom, spray the penis with either 2 sprays, 3 sprays, up to 10 sprays, depending on which one you're using. Allow it to soak in. But while you're allowing it to soak in, it doesn't mean you can't start start foreplay with your significant other. And so they'll spray it onto the penis, and typically it takes about 10 to 15 minutes to absorb and work. I do recommend you wipe off any excess for some of them, so you don't transfer it during oral sex or vaginal sex. And once that has happened, they're a great option for preventing premature ejaculation. There are 2 main types of delay sprays. There is benzocaine, which is the ester class. It doesn't have an amide bond, so it doesn't really stick around longer. It's metabolized in the actual bloodstream, as opposed to lidocaine, which undergoes hepatic metabolism. Lidocaine sticks around much longer and has a longer lasting power. So I tell my patients that this will typically start to work in 3 to 5 minutes, but really giving it 10 minutes will benefit you. The other things that I tell my patients is, foreplay for men with premature ejaculation is absolutely critical. And so if you can get a patient or if you can get your partner to orgasm without using penetration, you're already ahead of the game. So a lot of these men with premature ejaculation will spray a lidocaine-based delay spray on their penis, and they'll use oral sex or use their fingers to get their partner to orgasm, because they won't then have to rely on penetration for their partner satisfaction. And so the lidocaine sprays clearly are best. It's the longest lasting. It is the best absorption on skin. We see benzocaine have a better absorption on mucous membranes, which is exactly the opposite of what we want. And so when I talk to these patients, I say lidocaine trumps benzocaine every time. The only problem is benzocaine is cheaper and is more readily available over the counter. And so a lot of patients will start with benzocaine, not realizing it's an inferior product, and then move on to lidocaine once they have someone tell them exactly what they're doing. We don't see as much of it in this country, but clove oil, peppermint, different botanicals can be used. And although this causes a little bit of like a tickling sensation or is a reasonable option for people who don't have access to benzocaine and lidocaine, it doesn't really add much. Maybe it adds a minute. We see this in a lot of countries. I see it in patients who will do telemedicine appointments from India. Have a lot of times we'll be using clove oil, but I don't use this on my patients because I think there's better options out there. So when you talk about delay sprays, it's the nuance that matters. And so this is a lot of the origins of my companies developing a new delay spray. So Popstar set out to develop what we consider to be the best, most effective, safest, science-backed delay spray out there. But we also looked at what the patients were asking for. And so the absorption speed and non-partner transfer is critical, right? So we wanted a product, and you're looking for a product that will work quicker, last longer, and not transfer. And so that's important in picking one of these. The other one is the dose delivery system. Some of these just have thumb pumps. What that means is you just spray a whole bunch on your hand, but you don't know the actual dose you're getting. And so making sure you use one that has a metered valve that delivers the same 10 milligrams of lidocaine every time is critical to efficacy. The percent lidocaine you use is also variable. They're as low as 2, they're as high as 25%, although the FDA regulates in this country that it has to be less than 10% to be over the counter. And so one thing that people often don't think about is the cost and the surface area involved. And so if you're using 2% lidocaine, you're going to have to apply more, which means you're going to have to use more, which means it's going to cost more. But sometimes you run out of space in order to get the effect. And so 10% lidocaine tends to be that sweet spot where you're using the least amount, so the cheapest amount, and you're able to apply it to the penis without an additional extra sticking around, which risks partner transfer. When you're talking about convenience versus staying powder, I think lidocaine takes the cake here. Benzocaine will work slightly faster, but it's gone in minutes and requires reapplication, which in this world patients do not want to do. Patients are largely trying to hide this from their partner. They're usually working on pelvic floor physical therapy. They're working on sex therapy. They're playing the long game here. And so these delay sprays or SSRIs, which we'll talk about, these are sort of a short-term fix to keep their partner happy, keep them happy, and they do not want their partner to know. One of the main issues that we didn't realize, and that doing some market research, is that smell and taste is a big factor in this space. And if you look at all the brands that were available, many of them had like a medicine-y or a menthol type smell or taste. And so when we put our product forward, we developed a lidocaine-based delay spray that has no smell and no taste, which is important if you're trying to hide this from your partner. And then the side effect profile is largely the same. If you have anyone who has an allergy to lidocaine, the risks are really low, but we do worry that people can have mild burning. If it's an alcohol-based solution, they can have a rash to this. And so make sure the products that you're recommending to your patients are made in FDA-approved facilities, that they have all the regulatory patterns and third-party testing that is available. So the next option is, what happens when you have a patient who's using pelvic floor physical therapy, they're using sex therapy, they're doing training on their own, so they're masturbating with a delay spray, and they're also using it during the time, but they're just not getting the effect that they want. Or largely, in a lot of our practices, we're not really aware of these options and informed about them enough to speak. So the default is we go right to an SSRI. And in my practice, the SSRIs are second-line therapy, mainly because of their side effect profile. These do work, and they work well. However, they're not the easiest drug to use. Patients do have significant side effects with these drugs, and feeling safe prescribing them is something that a lot of urologists and sexual medicine doctors don't really feel comfortable with. And so paroxetine, sertraline, Paxil, and Zoloft are the two big ones that I use. There was an on-demand one, Depoxetine, known as Prilogy outside of the United States, that was put forward to the FDA in the early 2000s. That was went to the FDA for the indication of premature ejaculation. However, in 2005, the FDA actually rejected it. Not saying that there was anything wrong with it or that there were any side effect profiles that were a problem or adverse outcomes, but they thought the risk reward of approving an SSRI primarily for premature ejaculation was too risky, and it was rejected. This is available outside of the United States, and a lot of my patients will order this from online pharmacies. So be aware of this, Prilogy duloxetine, a short-acting SSRI that a lot of your patients will acquire. So what are the three big ones that I see in my practice? Prilogy is something your patients are going to obtain. The dose is somewhere between 30 and 60 milligrams. It's taken 1 to 3 hours before sexual activity. Its half-life is short, an hour and a half, and it increases your intravaginal ejaculatory latency time up to 3-fold. So a great option for a lot of men, however, not available in the United States. My go-to is Paxil. The dose is 2. You have 2 options for these patients. I start at 10 milligrams. I work my way up for these patients. Even though I do this at a high volume, I still get hesitant when I jump into the 30 or 40 milligram a day dose. Or you can give them 30 milligrams 3 hours, even up to 6 hours before sexual activity. The half-life is long. It's 21 hours. And some of the studies show your intravaginal ejaculatory latency time can be up to 10-fold if you're taking this daily. Another option is Zoloft. The dose 50 to 200 milligrams a day, 50 milligrams. But again, with a half-life of 26 hours, you have to take this 4, 6, even 8 hours before sexual activity. And for those of us who know ED meds and how men take these, 20 minutes before they're going to have sex, planning 8 hours beforehand sometimes can be an impossibility. And again, it increases your ability to last by 5-fold. I often get asked by my patients and other clinicians, do I use daily versus on demand? I typically go to on demand, but I will not hesitate to start daily Paxil. So how's it used daily? You take it once a day. I typically start at 10 milligrams. You take it daily, so it provides a steady increase in serotonin activity, increasing that serotonin, which is thought to delay ejaculation, up to 10-fold. It also has comorbid improvement in it also may include improvement in comorbid anxiety or depression. So be aware of these patients. Also be aware that these patients sometimes are already on an SSRI, and a lot of times working with your colleagues in psychiatry and in psychology can allow overprescribing or doubling up on medicines if you don't mean to do that. The cons of this or the downsides of this or the side effects are real. You'll see patients with a lot of GI side effects, so nausea, vomiting, diarrhea. Insomnia is a big one. I see patients get weight gain because of causing an increase in their appetite. The sexual dysfunction is mild. Usually we're working for that, fatigue. And also, I worry about people developing suicidal ideations. I worry about real serious side effects, serotonin syndrome. And so it takes about a week or two to notice some improvement, but I tell my patients to not expect real impact for up to 4 to 6 weeks. It must be taken daily, which is not always appealing for your patients based upon the frequency of their sexual activity. So in my older patients who are having sex once a week or once a month, sometimes an on-demand option becomes a better solution for them. On-demand Paxil is another good option. So 3 hours before, that can be a problem. I tell my patients, if you know for sure, based upon the half-life of these drugs, 6 hours is even better, although sometimes that's tough from a compliance standpoint. It's more convenient when your sexual activity is infrequent. It decreases the side effects. I will say that in the studies done on demand versus daily, the evidence for its effect is weaker and more variable. More like a 3 to 5-fold increase in intravaginal latency time. And so if you have a patient who really is bothered, can barely even penetrate without lasting, sometimes having the daily dose is what they need to get where they need to be. There's acute side effects, nausea, drowsiness, the GI side effects, and it's not as effective in men with severe PE as we were discussing. Your patients who have premature ejaculation will come in well informed about all of the options that are available for them. There is a cohort of patients who will take tramadol. This makes me nervous. This is a narcotic. It has been studied, but does have a risk of dependency. And again, addiction for men who have premature ejaculation these people will rapidly increase the dose. They'll take 2, they'll take 3, they'll take 4. So I don't write tramadol in my practice, although I do have colleagues in the sexual medicine societies who will write this. I am a big fan of Cialis. I think Cialis is important for men because it improves their erectile dysfunction. I also think it's important because a lot of these patients with premature ejaculation will ejaculate precoital. They'll masturbate before having sex with a partner because they can last longer the second time. But what becomes an issue for them is that refractory period in between. And a lot of them believe that taking daily Cialis shortens the refractory period. And for men who have erectile dysfunction, who are ejaculating fast because they're worried about losing rigidity and decreasing their partner penetration rates, daily Cialis can improve erectile function and then help with lasting power. There are also experimental therapies, alpha blockers, new serotonin-targeted drugs, and also oxytocin has a role in ejaculation. And so we'll use intranasal oxytocin for men with delayed ejaculation. And there are not a lot of studies. There are some studies that are ongoing and have been done into oxytocin antagonists in delaying early ejaculation. So can't give a lecture without talking about lifestyle and alternative approaches. All my patients, we talk about stress reduction. We talk about speaking to sex therapy, speaking to therapy. A lot of these patients have anxiety. And so stress reduction can have a huge impact on their quality of life, their lifespan, as well as their premature ejaculation. Exercise and diet improves testosterone, improves overall sexual health. And a lot of these patients will be taking supplements like zinc, L-arginine, herbal extracts, realizing these have mixed scientific support, but if there is a placebo effect, a lot of times they get a benefit from it. I'm not aware of a premature ejaculation supplement on the market. However, a lot of times they're doing their own supplement stack for sexual health. So the key takeaways, premature ejaculation is one of the most prevalent, multifactorial, and often distressing and misunderstood conditions in sexual medicine. There are both biological and psychological factors at play here. The overlap is large. The effective management combines behavioral therapy, sex therapy, pharmacology, and partner support. Advances in neurobiology may lead to more targeted therapies. Emerging devices and therapies aim to improve ejaculatory control. And as a team, we have to reduce the stigma and promote open discussions in improving outcomes. So that's my talk tonight about premature ejaculation. It's an incredibly complex subject. Each patient is different. Each patient has different goals of their treatment. A lot of these patients have tried a lot of different things. And by the time they get to your office, they're very stressed. Most of the time, their partner is not with them because the relationship is strained. And so having a approach to these patients that involves both the long-term play of sex therapy and pelvic floor physical therapy and the short-term play of using a delay spray, using a condom, using an SSRI, and training yourself work in concert to get these patients long-term success. So I think we have some time for questions.
First question here. Have you had success with multiple medically refractory patients, PRN, daily dosed SSRI, and lidocaine after a PFPT treatment?
Yeah. I mean, I have to point out that when we say refractory, we have to talk about the fact that refractory still is normal for these patients. Refractory and premature ejaculation are kind of, we're trying to work against Mother Nature or God or whoever you believe in to make you last longer when everything about sex is about procreation, largely. And so it is an uphill battle. And so I have had success, but it's the long game. And when we talk about pelvic floor physical therapy for patients who don't get immediate success with delay sprays, don't get immediate success with SSRIs, have severe premature ejaculation, I continue down the same path, right? Because just like going to the gym, if you work out your bicep once a day, twice a day for 3 weeks, for 3 months, you're not going to be the Arnold Schwarzenegger of biceps. It takes a lot of time to train the muscles of your pelvic floor to work in concert to avoid premature ejaculation. The same thing with your bicep happens to your pelvic floor. So even for men who come in to see me who are refractory to everything acutely, I think they're the ones who benefit the most from pelvic floor physical therapy because they have the most to gain.
Certainly. Alrighty. Next question here. How do you clinically distinguish between lifelong premature ejaculation and acquired premature ejaculation? I guess we covered that a little bit tonight, but someone did.
Yeah, I mean, via an H&P. I mean, asking these patients how long they can last, they will tell you down to the second. If they have had this issue their whole life, they will know. From the first time, they can often pinpoint my first partner, my first few sexual experiences, it was horrible for them. And they know that it has always been this way. For the patients who have not had lifelong PE, who it's acquired, they can often pinpoint the event that made this happen. And so the main difference for me is I'm more critical of the patients who have acquired PE because I'm more concerned about a cause. And so I'm making sure that I'm, checking their thyroid panel, checking their testosterone panel, asking them about their nerves, asking them about other biological mechanisms, trying to figure out if there's a treatable cause.
Definitely. All right. Next one here. In men recovering from prostate cancer treatment, how common is premature ejaculation compared to erectile dysfunction? And are they mechanistically, I don't think I said that right, but mechanically related?
Yes and no. We don't really understand the incidence of premature ejaculation in the context of prostate cancer. The reason why is because premature ejaculation is oftentimes lumped in the category of ejaculatory dysfunction. And the ejaculatory dysfunction can include painful ejaculation, dry ejaculation, and the incidence these after prostate cancer surgery is much higher. And so teasing out the men with premature ejaculation after prostate cancer has largely not been done yet. Mechanistically, very different. I mean, I think we understand that ED is nerve damage. Why men would develop premature ejaculation after prostate cancer is more related to changes that happen in the anatomy of the pelvic floor. You remove the prostate, you move the seminal vesicles, you reanastomose the bladder to the urethra. The architecture of the pelvic floor changes and the sensitivity may change. And so although there is some overlap in that prostate cancer changes the pelvic floor, I think ED and premature ejaculation are largely different in the cause and largely different in the treatment.
Certainly. Okay, we got a couple more here related to prostate treatment. So what role do physiological factors such as performance anxiety post-cancer treatment play in premature ejaculation compared to purely physiological causes?
I mean, psychology is always huge in these patients. And so if you're talking about a man who develops premature ejaculation after prostate cancer treatment, a lot of times the commonality is anxiety. And so anxiety about sexual performance is incredibly common after prostate cancer treatment. Because these men have difficulty with erections, their sex life is different, they have dry orgasms, they claim their orgasms don't feel the same. And so premature ejaculation often happens as all of those things come together. And what we know is that with 70% of men who have acquired PE also have anxiety, the overlap is the same. It's the serotonin issue. And so it's kind of a vicious cycle because these men develop difficulty with painful ejaculations. They develop difficulty with erectile dysfunction. They're in bed. They're overthinking their performance. They're critical of themselves. They're developing anxiety. And the next thing that happens is premature ejaculation.
All righty. One more prostate question here. So does incontinence and pelvic floor dysfunction contribute to ejaculatory disorders in these prostate cancer survivors?
I mean, I think we talked a little bit about that in the last question. I do think prostatectomy following a prostate cancer diagnosis does change the pelvic floor, which I think is indirectly also linked to incontinence. And so any sort of anatomical changes to the pelvic floor can increase sensation, can cause premature ejaculation. I often think there's an overlap between prostate radiation for prostate cancer and inflammatory conditions like prostatitis. So that inflammation that happens following radiation therapy and the prolonged inflammation that happens from cellular damage can lead to heightened sensation as well. And so anything you're doing to that area that's having an impact on sensation and nerve conduction can lead to issues with premature ejaculation.
Alrighty, and we have our final question here is a good wrap-up question. So do you foresee gene therapy, neurostimulation, or any other emerging technologies playing a role in the PE management in the next decade?
Yeah, let's hope. I mean, I think we understand that the serotonin and serotonin receptors are largely controlling ejaculation. I mean, dopamine's at play, oxytocin's at play. And so targeting those receptors and targeting those neurotransmitters could potentially work, but they're so broad in what they do that we have to be careful about what we're doing. And so gene therapy targeting those receptors, gene therapy targeting the neural pathways at play definitely is an option. I do think neurostimulation is an interesting concept. In the same way that we do posterior tibial nerve stimulation for overactive bladder, in theory, we could do posterior tibial stimulation for the ejaculatory center. I don't know if it'd be the posterior tibial nerve, but in a way, we could work with the dorsal penile nerve, sacral nerve latency studies, understanding that pathway. There are surgical options for cutting the dorsal penile nerve. I don't do those in my practice. I have had patients who've had it done. And so any sort of neurostimulation at the level of the afferent nerves or at the level of the spinal cord does offer an interesting play. I think what I'm seeing in my practice more commonly, and what I think the future over the next 5 to 10 years, is data-driven solutions for premature ejaculation. So app-based solutions with training, real-time tracking, allowing patients to understand the impact of a delay spray, the impact of pelvic floor physical therapy, seeing progress, seeing that dopamine-induced reward network, reward sort of pathway happen, I think actually leads to better outcomes. So I'm optimistic that as we have data-driven options and solutions for men to track and monitor their premature ejaculation, I think we're going to get better outcomes. And so that's where I see the short-term future. But again, neurostimulation and gene therapy, of course, they are reasonable options in the future. I just don't see them in the next 5 to 10 years.
Thank you for taking the time to answer those questions. We'd like to thank Dr. Brian Steixner for presenting tonight and thanking everyone for joining this MenMD online clinic. We hope you found this discussion valuable and that helps you in your practice.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available.